Hello, everyone. I'm Traci Arieli, end-of-life doula and founder of Comforting Closure. Welcome to today's episode, where we're going to talk about the process of dying and address the fears that many of us face. We're joined by a guest who has dedicated her life to caring for those at the threshold of death and empowering families with knowledge. Gabby Jimenez is a hospice nurse, an end-of-life doula, and a death and dying educator. She's written several books on the subject, including one that she just co-authored called The Doula Toolkit. Gabby, welcome, and thank you so much for being here.
Thank you for having me, Traci.
Can you start off in telling us about your journey into end-of-life care and how you became a hospice nurse, end-of-life doula, educator, author?
Well, that's a whole nother podcast, so that might take some time, but I'll give you the short version. I decided late in life, at around 45, to start working in this field because I was caring for a friend of mine who was dying. And although I had had many experiences with death, many family members, many friends, I don't think I really understood it until I walked alongside him on his journey. I watched this really strong man become weak and dependent. And it was really hard for me. And I watched the hospice team come in and take care of him, and they were just so lovely. And I felt like that's what I was supposed to be doing. And at the time, I was making a lot of money at a job that I could have done for the next 40 years if I wanted to. But I realized that it wasn't about that. I think for the first time in my whole life, I realized that you can do something that fills your passion. And so I went to school to be a caregiver, and I got rid of my home. I moved out, rented a room because that's all I could afford. And I worked full time during the day, and I went to school during the night, and I became a caregiver, took care of the elderly. And while I was taking care of the elderly, I realized how dismissive people can be towards them. And when they're starting to decline and their bodies are weakening and they are dying, there wasn't really adequate enough, at least from my perspective, information or education that could help their family to care for them. And I didn't know this stuff. And so I wanted to do more. And I decided to go to school to become a hospice nurse. So at the age of 47, I went to college. I became a hospice nurse. And that was the training. It took several years before I really understood what that meant. And I learned so much from so many people. And the difference between a hospice nurse and a doula, for instance, is that the hospice nurse has to follow protocols, and we do not have the luxury of time. And so we see a patient, we leave, we go see a next patient, and the other members of the team see them as well. So they're getting a lot of support from a collaborative team, which is a beautiful thing. But I wanted more. I wanted to give them more. I wanted to be more present. So I became a doula, which helped me to understand the depth and beauty and sacredness of death and dying, and what it truly means to be present or hold space or show up. And I became a doula so that I could spend more time with them. Being a doula has made me a better nurse. And being a doula when I'm with my private clients allows me to spend a little time longer than I might as a nurse. But in both situations, I get to offer ritual and ceremony, which is what I love, and a little bit more comfort and support, allowing them to navigate this journey with a little more ease and grace.
There's an immense amount of fear surrounding death, not only watching our loved ones go through it, but as well as facing it ourselves. You've witnessed many deaths, and I want to talk about some of the fears that people have. I want to begin by talking at a high level about what occurs as a person approaches death. And I know that when I'm working with a family, they want to know what to expect. They want to know when they can recognize when things are getting close. And I always tell them to look at three things: how aware or engaged their loved one is, how much they're sleeping, and how much they're eating and drinking. What do you advise people to look for?
Good question. There is a lot of fear. but I think fear is wrapped around the unknown and the uncertainty. I have learned that once you educate people and just really help them to understand that most of what they're witnessing is a normal part of the dying process, fear is reduced. Things like breathing changes. We as a team cannot predict how someone is going to die. Some will close their eyes and die in their sleep. Some will have pain and discomfort and restlessness and agitation, and some will just kind of ease through it and maybe a few breathing changes, but all of that is normal and no one dies the same way. And so we have to be prepared for it all. When someone is nearing sort of transitioning towards actively dying, things like what you mentioned, they might sleep more, they might eat and drink less, they may be less communicative, they might withdraw, they might even get angry. I believe that everyone, even up to those last breaths, has a certain sense of awareness of what's going on. And I imagine that the dying process itself, knowing that you are dying, having to take that in and be with that is really hard. But also knowing, whether you're verbal or nonverbal, knowing what your friends, family, loved ones, and anyone in the room is experiencing while they're watching you die, that is a heavy weight to bear. So while you might hear a person moaning, for instance, it might not be physical pain. It might be emotional pain or spiritual pain. And I think that's what I witness most is the changes in the body, the way it moves, the way they might breathe, their eyes tell me everything. I am a nurse, but I do not take vital signs unless I'm asked to. And my reason for that is because I don't want to rely on a number. And I want the families to look away from the numbers in such a way that they can check the breathing and check the way the body's moving and look in their eyes and say, they're getting closer. But fear comes from sounds, I think, most of all. It's the sounds someone might make, the gasping breaths. Some people will die quite peacefully, but their breathing sounds might be rapid. They might do sort of the guppy mouth breathing where they open their mouth slowly and just take little breaths. They might move a lot. They might call out. The sounds that people hear, the death rattle is probably the biggest one, right?
Yeah.
People are so afraid of the death rattle. And I get that. It's a horrible name, but the reality of it is that's a part of the death and dying process. If you tell someone and just a few little words, first of all, you need to understand that this bothers us more than them because it's a sound. This is a normal part of the dying process. It doesn't happen for everyone. But if you imagine the inability to bring things up and down, your swallowing is affected, right? And maybe there's a little saliva that's just resting there and it will vibrate. And sometimes that's a loud vibration sound. And that can be scary. And it sounds, to some people, it's traumatic and horrifying. And I'll just say, just roll her over onto her side just a little bit. And we can loosen up the secretions that are there. And that might quiet the sound. And oftentimes it does. If you tell them the what and the why, if you prepare them ahead of time, if you give them some tasks, some tips and tools that they can do, fear is reduced.
The terminal secretions or the death rattle is one that everyone kind of is very uncomfortable with. And they really worry that their loved one is in pain. But, once I explain, it's the brain isn't telling the body to swallow anymore. They understand it. It doesn't make it any more comfortable, but at least they know that their loved one isn't in pain. And yes, turning them on their sides is really helpful. And I know that there are some medications that help with that also. I prefer to turn the person on their side versus giving that medicine that will dry up that, because that means everything's drying up. But everyone
That's
does.
exactly right.
Yeah.
We used to use those all the time, back in the day. But there's two things. One is you're absolutely right. It dries out the mouth and it's the secretions are in the throat, in the
Yep.
chest. Sometimes they are in the mouth, but they're already dealing with a dry mouth. Why make that worse? But the other thing is medications like atropine has a side effect of hallucinations. It doesn't always happen, but it can. Well, that alone makes me not want to use it, and I think, why add more discomfort, whether it is a hallucination or simply a dry mouth? Why put them through that?
Yeah.
So I think that people need the education first, because the other thing is they want to use a suction machine. Can you please order us a suction machine? I usually will spend about 10 minutes telling them why I don't like using the suction machine. But if you educate them and help them to understand that this is all a normal part of the process, they do feel a little less scared.
Let's discuss food and water. Now, this is a big one. There are many distressing things that the family witnesses when a loved one is ill. And one of the most upsetting ones is when a person who is ill stops eating and drinking. Our instincts, of course, are to get that person to eat and drink. Can you talk about that a bit?
Yes, we equate food and water to love, right? We are loving a person when we are cooking for them and feeding them, and caregivers, especially, whether partner and spouse or hired caregiver, they are taught and trained and have been feeding this person for however long. That's part of their routine. It's part of their contribution to their care. And when that is taken away from them, they feel like they are hurting that person. And it's a very hard adjustment to make. What people don't realize is that food and water at the end of life actually causes the body a little more struggle to let go. It lets go easier without the food and water. Our body doesn't need that. We use food and water to nourish and energize our bodies when we're healthy. But when we're dying, it kind of sits there as a heavy weight that blocks the ability to just relax and let go. When someone is not eating and drinking for several days, I truly believe that their death is a little more peaceful because of that. But you have to educate the family. The thing that I try to do is, when I suggest to the family that they stop, I don't like to use the word force, but sometimes it feels like they're forcing their person to eat and drink. I will give them something else to do in lieu of that, because they've been doing this for so long. We need to respect that. But there are also signs that people I don't think they notice or recognize as warning signs that this person is struggling with swallowing. And if they know that too, then they know that they need to pull back. Like little things, like first one I look for is the straw. If they start coughing when they're drinking with a straw, I know they need to pull back on the straw. The straw is designed to fill completely up and then shoot everything into the throat. That can cause a person who's struggling with swallowing some fear, and it could cause them to choke. The other thing is that I've noticed is that with liquids, water especially, more so than other liquids, when they drink the water, they might cough. If they're coughing with water, I know that they're starting to struggle with swallowing. Now, the go-to is to give them thickened stuff in their water, which no one really wants to drink thickened water, right? It's kind of gross. But they can switch to other juices and see if that works, because there's a different maybe concentration in water versus juices. And so if you just switch from the water to the juice, that might make a difference. But as they go along, there's other things too. They might pocket their food in their cheeks. They're going to take the food in, they're going to swallow it because it's being given to them. And maybe they don't want to hurt or offend the person that's doing it, or maybe they feel like they don't have a choice, and they'll pocket it and it'll sit there. And then they'll either choke on it, which happens often, or they will spit it out. They also might purse their lips close or shake their head no. All of that is them saying, I can't do this anymore. And what I want to encourage caregivers of all, whomever they are, providing this care to this person, is to acknowledge those signs, because this person is telling you they can't do this anymore. And if we listen, it'll make things easier when that time comes when there will be no more food and water. And again, at the end of life, the body doesn't need it. It would do better off without it.
The body knows when or how to die. And I love how you mentioned that when you've witnessed people who have stopped eating and drinking and been given that grace to stop eating and drinking, that it looks peaceful, that they go pretty peacefully. And I know that from a biological perspective, that's because you're not eating and drinking and your electrolytes are kind of out of whack, and your calcium goes up. So the human, so the body is really great. The calcium levels go up, and you kind of fall asleep and pass away that way, at least ideally, right? But the human body knows what to do.
The human
Physically.
body knows what to do. That's like the best advice we could give anyone, is to trust that. But the thing to know, though, and this is what people don't realize, I just taught a class yesterday and I was talking about this exact same thing. And I said, I have been with a woman who didn't eat or drink for 19 days. And a woman in the class raised her hand and she said, I was told that if you don't have water for 3 days, you could die. And I said, that is not true. I think some of us could. Same with food. Personally, I can't go 3 hours without food. So 3 days would probably be my demise. But I think people don't realize that the body is a miraculous, so miraculous, right? And it can sometimes go a very long time without food and water. Now, this woman who went 19 days, she was in her bed. She was not in pain. She didn't make noise. She didn't move. They kept her clean and comfortable, but she did not have food or water for 19 days. Now, if I'm going to go to a deep level of I think she was already gone by that point spiritually, her body was just sort of taking its time to let go. That's what it looks like to me, because I think at that point there is nothing else going on there. The awareness has left. But I had another woman who just recently was 11 days without food and water. And she would periodically open her eyes, or if you would say something, she would kind of go, like, kind of in response. So when does the awareness leave? I don't know. And how long can each person go without food and water? I don't know. I think that each person dies differently. Our bodies are different. We can't predict what will happen. We can just let them know what could happen.
I know many people think that the act of dying is a lot quicker than it actually is. And you just said, you talked about how someone thought that, hey, 3 days without water, that person should be passing away, should be gone. I remember when my cousin passed away, and her brother was talking because her brother was with her. And she was very spiritual, very, very spiritual. And as she was getting sicker and sicker and nearing death, she questioned why it was taking so long. I mean, she questioned why it was taking so long. She thought that it would be so easy just to let her body go. Do you find that people don't realize or are generally unprepared for how long the dying process can take?
Yes, I think that once they've made peace, for lack of a better word, with the reality that their person is dying, then it should happen soon, right? Okay, so the diagnosis happens, the decline happens, they get closer and closer to actively dying, they stop eating and drinking, perhaps they're less engaged, they're no longer verbal, all of that happens, right? And they've gone through this process. And the people at the bedside are ready. They know their loved one is dying. And then they don't, day after day. So after about the third day, which is as far as most people can go without getting frustrated or uncomfortable, right? Because now what do? Do we sit here day after day? And that's actually when the conversation is really kind of elevated, which is the body knows what to do. And we have to trust that. And I will always say hours to days. And what that looks like, we can't predict. I will never tell a family, oh, it looks like she could go 2 or 3 more weeks. I will never do that because I don't know that. I'd rather say it could be hours to days and end up taking a week or two, because at least they were prepared. And when I see that the body is kind of starting to shut down, and how long that takes is uncertain, I will say, imagine today is your last day with her. Say all the things, make sure you express all of your feelings, right? Sit with her if you need to, play music, do all this beautiful things for her. And if you have tomorrow, that's a bonus day, and do it again. What I don't want is for people to keep going thinking, oh, well, we've got more time, and not say the things, not be present. But when it goes on to about 3 days, I give them permission to walk away. Like if you need to go take a shower or take a nap or eat, it's really important that you practice self-care. But the one thing that I always say to them, if they should walk away, if they should go take a walk or take a nap or take a shower or go to work, I will say, I believe this with every ounce of my being. They do not take with them who was there at last breath. They take with them who was there all along, right here in their heart. So if you should walk away and that's when they take their last breath, perhaps they didn't want an audience. Maybe they didn't want you seeing that and having that be the last thing you witnessed. Maybe they just wanted some privacy. It's okay to not be present at that last breath, as long as you have made peace with the last things you've said or done for them. But it could take days, many days, and that is not predictable.
Parents are want to protect their children, and so many parents will wait until people have left the room to pass on. I've seen that a couple times.
I do think there is a certain sense of intention. I mean, we don't know, right? We can only imagine, but I've witnessed over 2,000 last breaths. So I've seen enough death to know that they're going to do it their way. It's not always their way, right? But it's not about us. So we have to just accept that this is how they're going to die. If we can remove pain and suffering, then we've done something well. After that, we have to let the body do what it needs to do.
Speaking of pain and suffering, many people are afraid that that the painkillers that are provided will speed up death or hasten death. What are the typical medications that are provided, and why should people not be afraid to administer them?
Well, people are afraid. I think any normal human being handed a syringe of morphine and asked to give it to someone they love will freak out. I think they're very afraid. We hear so much about that, right? And I can't tell you how many people have said, my mom was on hospice, they gave her morphine and she died. Here's the thing. When you get on hospice, right, you're given 6 months or less to live, which means you have a terminal diagnosis and your time is very limited. When you start hospice, you are given a kit of medications. Some call it a comfort kit, some call it a system relief kit, which is what we call it. And we shorten it by calling it an SRK. The SRK has 5 typical medications, but the 3 that are related to symptom management are usually morphine, Ativan, also called lorazepam, and haloperidol, which is also called Haldol. Morphine is typically for pain or shortness of breath. Ativan, lorazepam is typically for agitation, anxiety, and restlessness. And haloperidol, which was used more still probably used for schizophrenics. So you can imagine the voices, the confusion, the hallucinations, the delirium. And so we use that for confusion or delirium, but it's also been found to use to be good for nausea and vomiting. It's actually brings relief for that. All of these collectively can work for pain and discomfort. What we have when we give these medications is a basic order. We call it a PRN, which means as needed. And each bag of medications comes with your sort of typical order. Now, let's say you have a 1 ml syringe, which is usually about the length of a pen. Okay, no needles, just to make sure everybody understands that. In this 1 ml syringe, we will only give a quarter of that, which is 0.25 mLs. That's what our PRN as needed order is. That little amount of that medication, which is the initial amount that we will start with, is not enough to hasten death. I have other patients who might, their symptoms weren't being managed, that we needed to give more. We might give them a full ml every hour. We could do that for days before they let go. So the amount of medications that we use typically, unless we are doing something like palliative sedation, are not going to hasten death. But it's really important to know. Someone will ask me, can they die after taking these medications? Yes. Not because of the medications, because of the illness, the diagnosis, the disease process. These medications tap into the body in such a way that they can go to the places that are struggling, and they can calm them just enough to allow the body to succumb to what it was already doing anyway, and maybe allow it to die with peace and ease and grace. And that's just one of these medications. Sometimes we will pair them up. We will often pair morphine with the Ativan or lorazepam. People think that's, and now you're doubling up the medications. Will this kill her? No, this will not kill her. But what people need to understand is where we come from the perspective of these medications. If you are in pain it can increase your agitation. If you have agitation, it can increase your pain. If you take morphine and lorazepam together, it can simultaneously bring down both. So when we are offering to give these medications, it's coming from a place of experience and education, of course, but also knowing that we want to reduce the suffering. We don't want to end the life. That's already happening. But the medications that we generally give are not enough to hasten death. So when we say to your loved one, can you give this morphine every 4 hours, for instance? It's not going to end her life unless the fight that she's experiencing within is able to be calmed by that medication, and she can let go. She was already trying to let go. The body was already doing what it needed to do. It was just having some struggle with it. And if people hear that, they're less likely to be afraid. And usually what I will use is a syringe as an example, and I will show them. I have syringes in my pocket, my scrubs pockets all the time, because I want to show them the syringe. This is what it looks like. This is where the medication is. If they can have a visual like that, they'll be a little less afraid.
As people reach the active dying stage, which could be, as you said, the last days or the last hours of a person's life, many stop verbally communicating. How can their loved ones know if they're in pain, and what can they do about it besides giving the painkillers?
So there's a couple things. I look at the body. I let the body guide me. That oftentimes there will be some facial grimacing, and you'll see in the forehead, the wrinkling of the forehead. That will tell me that someone's in pain. A lot of times maybe their face will scrunch up, and that'll tell me. Their fists will clench, their body will move. I am not a pusher of medication. I think as a society, we have kind of turned into this medication pushing group, right? Like everybody's pushing a med for something. I want to first see if that person is in pain, that it can't be remedied by perhaps maybe unscrunching up a t-shirt in the back, or putting a drop of water on their dry tongue, or turning a light above their eyes, or maybe changing their wet brief. Maybe if we do that first, they'll be a little calmer. Maybe they're telling us that something is not right. So I want to address those things first. And if that isn't, then I will look into giving medications. But I think there are a lot of things that make a body uncomfortable when it's dying. Internally, if it's pain or physical reaction to the dying process, they will usually tell you with their face. And again, there's moaning too, but moaning doesn't always mean physical pain. So I want to first assess the person, see what they're experiencing. Oftentimes it could be a wet brief. They actually will not be talkative for days. They'll be totally peaceful, and they have a soiled brief, and that'll be enough for them to move around. So I think we need to trust that the body knows not just what to do, but how to let us know if something isn't right.
Now, many people who are dying have visions of loved ones who have already passed away. When do those begin, and what do you believe they are? Because science doesn't know, right?
No, and I don't know either. I mean, I'm just giving you my perspective. It doesn't just happen at the end of life. It could be months or even years before that. Some people just have, I don't know, maybe luck or just permission to see things earlier than others. What I feel is, in general, on average, a person who is within the last few weeks of their life, it's as though this sounds so kind of corny, but it's as though a curtain has been opened, and they are invited to see things that we don't get to, such as people that have passed away and are there hanging out. They're coming to their room. They're sitting outside their window. They're talking to them. I have seen people have full-blown conversations with someone. I've seen it so many times that I'm absolutely certain that it happens. We don't get to see that. That's not our gift, right? It's not our time yet. Often the way I know that this is happening is they will sometimes stare up at the corner ceiling, right? Or halfway down the wall. Sometimes they'll look up and they'll just start doing this. And I often think they must be preparing to take someone's hand, like someone is extending their hand saying, it's okay, I've got you. And so when the family says, what is she doing? She's hallucinating, she's freaking out. I say, no, She told me she saw her aunt and she was talking to her, and I told her that her aunt died years ago, and why is she acting like that? And I said, no, no, no. Embrace this. This isn't scary. Ask first. Are you afraid? If there's fear, we'll address that. That's a whole nother thing. That's hallucination. These are visions that happen at the end of life. And if someone is there talking to them, someone has taken their hand or just shown up in their room. If there's no fear, I'll say, who is it? What are they saying? What are they wearing? You know, what are the conversations that you have? Because they do see it. And it's not for us to question. And I've seen other things too that just blow my mind. I had one patient who, it's actually one of my favorite stories. I was sitting next to his bed and he said, Gabby, I think I'm dying soon. And I said, I know. And he goes, no, I think I really am. And I said, okay, well, what's bringing this up? And he said, my dogs have been jumping up on my bed. And I said, I didn't know you had dogs. And he said, no, my dogs who have died. And he puts his hand on the bed as if to pet a dog lying there. And he says, they're here with me now. Does this mean I'm dying soon? And I said, yes. And he said, is this what he said? Something like, I can't quote him now, but he said something like, is this the gift that the dying receive? Is visits from those who have died? And I said, yes, I think that's true. And he just pet his dog as though that brought him peace. People see animals that have died. They see people that they've known who have died. They see people they don't know who they are, and they have conversations. As far as when does it happen, on average, it happens mostly the weeks or days before they're dying, but I have seen people who have had it far longer and way before that. But it is real. I do believe that this is not something, it's just too many to make up. The fact remains that we just aren't privy to it. And so because of that, we don't believe it. But I think we should really kind of be open to our curiosity. And instead of saying that can't be true, say, who are they and what are they saying? And how does it feel to have them there? Because I think once we accept the fact that most people are not afraid, then that should bring us comfort. Because to me, it reminds me that they're not going to be going on their own, that someone is going to be there to take their hand.
There's something called the rally or terminal lucidity. Can you tell us more about that?
You know, I haven't actually seen it that much. It's not something I see often, but basically what it is a person is, I'll give you an example actually of a gentleman who he was staying in our hospice house, and it's actually a beautiful story. He was a homeless man that they found on the street, and he was dying, and the hospital wouldn't take him. And so they asked us if we would take him at our hospice house, and we did. And we brought him in, and he was not very responsive, but he was, you know, he was kind of sitting up. He was not clear with his words. Our team bathed him. They got him in this cozy bed, put on cozy jammies, asked him if he wanted anything to eat. And he said he wanted pie. And we said, okay. So we gave him some pie, and then he went to sleep. And he was asleep for days. And we just kind of waited for him to let go because he was actively dying. He woke up and he said, can I get another piece of pie? And like we just said, okay. So we went out, we got him a piece of pie. He had a few bites. He laid back down and he died about 20 minutes later. Sometimes people will be completely non-responsive for days, maybe longer, and they will out of the blue say something. It's like this surge of energy, this awareness that maybe they're close and they just want one last word. I had a woman, actually, this might bring me a little bit in tears. I had a woman on Friday who I have been doing her wound care for a year, right? I change her wounds every day. She has never spoken to me. And I always talk to her, even though she doesn't speak. I always talk to her. I'm moving you here. I'm doing this, right? Well, yesterday their staff was so busy, so I couldn't get anyone to help me position her. So I had to do it myself. And she had a soiled brief, so I'm going to clean it, right? And I cleaned her, but I had to move her myself, and she's a little contracted, so it was hard. And I kept apologizing. And I said, I'm sorry. I know I'm not good at this. I'm trying to be gentle with you. And I'm talking to her and telling her everything I'm doing. And I changed her dressing, and then I kind of repositioned her, and I got her super cozy, and I fixed her hair a little bit, and I kind of rubbed her cheeks, and she leaned in like a small child, like she was enjoying this, right? And never talked to me. And I I said, I hope you know that I tried really hard to be gentle with you because I want you to be comfortable. And she says, thank you, as though she'd been talking for years. She didn't say another word the rest of the time I was there. No one has ever heard her talk. Now, she could live another couple of weeks or months. I don't know. But I think sometimes we don't give credit to the people who don't have a voice. We treat them as though there's nothing going on, but there is so much going on. And maybe once in a while, they're gifted an opportunity to speak up. It might be for a piece of pie, it might be to say thank you. Does it happen? Yes. Is it natural and normal and part of this whole process that we call life and death? Absolutely. Does it happen all the time? No. But sometimes people will wake up and they might say something. The downside of this is that oftentimes the people at the bedside will say, does this mean he's going to live longer? And they'll hold out hope that this means they're going to have more time. Very rarely do they continue conversations. It's just this little glimpse at the end of life where they have a moment to be able to speak or do or say something, and then they go back into what they were experiencing. And sometimes it's scary, but most of the time it's beautiful.
One of my personal fears is not being able to breathe. And I know morphine helps with that. But I've seen as a person nears death, there's the Cheyne-Stokes breathing, and then there's the agonal breathing or the gasping breath that you talked about before. Can you talk about those breathing changes, as a person reaches death, what those look like?
Yeah, there's so many different ways people breathe at the end of life, and you named them. And, some are rapid, some are sort of gasping, some are very slow motion. Oftentimes when they're getting closer to death, they can't breathe and pull air from the abdomen or from the diaphragm. So it's just up here, which might make them shorter breaths. But your fear is mine too. It's the fear of suffocating, the fear of not being able to catch my breath. And I've seen the look on their face when they can't breathe. And people will automatically want to put oxygen on, but very rarely, and keep in mind, our patients are in homes. They're not in a facility hooked up to big machines of oxygen like you would at the hospital, for instance. They will keep them on oxygen 24/7, but that too will not stop someone from having those breaths. But when someone's sitting at the bedside and their person is gasping for breath, it's really scary. And it scares me too. And usually what I will do is elevate their head, the head of their bed up so they're sitting up, because you imagine you're lying like this, right? Or even like this, there's very little room for air. But the more you sit up, the more that opens. Oftentimes that'll help. But I have found that, and this is just what I do, but I have found that if I can get them to focus and distract them from their fear and maybe rub their back, usually I'll rub their back or their chest. It's okay. It's okay. I've got you. I'm right here. Then I could breathe them down, because panic just exacerbates what they're experiencing. You can give them some medications to calm them down, morphine for shortness of breath. You can give some lorazepam for the agitation, and that will oftentimes help as well. But I found that most often, if I can talk them down from that it helps. And oxygen could help, but it doesn't always help. And I think that we have to be comfortable with the different sounds of breath, but also, like you asked, is how we can reduce that and help the families to know what to do. First thing would be to sit them up, or to take any pressure off their back and chest so that they have a little more room to allow breath in there. But also to distract them, help them breathe, talk them down.
What can family members and caregivers do to help their loved ones be more comfortable?
In what regard?
Um, As a end of life doula myself, I always talk to the person. Hopefully, I get called in while the person is still cognizant, and we're planning. So I know what kind of music they want, or I know the environment, what to do with the environment. Do you have these type of conversations with your clients also? And if the person who is ill hasn't had the opportunity to speak on their own behalf about what they want, what is a good death to them, how do you have that conversation with their loved ones?
Okay, so I wrote a blog probably about 2 years ago. I just reposted it on the Hospice Heart page, and it's getting such a big response to it. And interesting how I think it's getting more of a response now than when I originally wrote it. And it's called the five senses. One of the things that I do when I assess whether it's a patient as a nurse or as a client as a doula, is I think of the five senses. What do they see, hear, feel, touch, smell? I look around the room. Is a light bright in their eyes? Are they able to hear something, music, for instance? I remind families that when you're sitting at the side of the bed and you're tapping on their phone, they know that. When you whisper, they know that. Be mindful of the sounds that you're bringing in, dragging across a chair, right? Things like smells, everything is elevated. Hearing is elevated. I think all of your senses are elevated. So smells, people, this is a good example because I personally think roses are beautiful, but I don't want a bouquet of them next to my bed. I think stargazer lilies are lovely, but the smell it gives me a headache. So these smells next to their bed could cause them a lot of distress. And if they can't verbalize their need, they are sitting there having to suffer with that. If you provide care for someone who is dying, whether it's a family member or you're hired to do it, you need to make sure that you use unscented laundry detergents, that you don't put on scented lotions or shampoos or hair products or perfumes, because you're bringing in scents that could cause someone a lot of distress. In fact, more so than many things, even more so than sounds, smell is a very important one to be mindful of. But also touch. I have witnessed, I'll be sitting with a patient or a client, and a nurse or someone will walk in and just go right up to them, stick a syringe of medication in their mouth, or start moving pillows, but not acknowledging that this is a human being and they are not dead yet. If they are aware, then they're aware of bad care. So, what we need to do is be mindful of all the things that they can feel, hear, smell, taste, see. Make it so that we address all of those in such a way that it could bring them comfort. I think if we do anything at all, it's addressing those. Things like a wet brief can cause someone so much distress, as I mentioned earlier. If we keep them clean, if we position them well, pillows are my favorite because pillows can really help to comfort a body, especially if they're in a hospital bed. When you are in a hospital bed, your shoulders and back and arms are kind of sunken down. If you put pillows under someone's arms and elevate them just enough, they don't have to use their body strength to hold them up. It takes pressure off their back. If you elevate the foot of a hospital bed, it takes pressure off their back and bottom and hips. Also helps with reducing some pressure sores, which are going to happen usually anyway. No matter how clean a person is, depending on the fragility of their skin, they will get one. But comfort comes from the physical being. What does that person feel? What do they see? If they're in a hospital bed and they're looking at a wall, put something beautiful on the wall, or turn the bed so they can look out a window. Be mindful of the noises you bring in. Be mindful of the scents. Be kind and considerate when you touch them. Let them know that you're there. Let them know who you are. Let them know what you're going to do. Even after a person has taken their last breaths, I will say, "Hey, Bob, don't worry. I'm just going to straighten your blanket here. I'm going to fix your hair. I've got you. I'm going to move your arm a little bit. It's a little scrunched under. I'm going to change your brief. I'm going to remove your catheter now." Whatever it is I'm going to do, I will tell them, because that is a human being and they deserve respect and care and compassion. And so I think in answer to your question, it would be honoring those. I think people think they need to do big gestures. right? Should I bring in this? Should I do this? If you just tap into their five senses, and especially sound, because hearing truly is they say the last to go. I think it's all of them, but they hear, right? So they hear you crying, they hear you complaining, they hear you busy doing other things, they hear you whisper, but they also hear the I love yous, the thank yous, and the goodbyes. So rely on that. And I think if we address those things and we just understand what it truly means to be present, then that in itself can be the comfort that someone needs.
What advice do you give to family members and caregivers for to help them prepare emotionally for what is happening?
I don't think you can help someone prepare. In fact, no matter how much time they've had to plan, this wife might have been caring for her husband for years, right? And started hospice knowing this moment would come. Saw the decline, the hospice team comes in and the last breaths happen. She's been prepared for however long since diagnosis. But when that last breath is taken, it's as though they had absolutely no idea it was coming. So that tells me that there's nothing we can really do to prepare. But what we can do is visit with them, ask them, how did you meet? If it's a partner, or if it's your child, or if it's your parent, what are your favorite memories? What are the things that you'll take with you when she's gone? Because when you start talking to them like that, it helps them to realize what the reality is. This person is dying. The people I see are dying. I don't usually get many people months, years before. It's usually someone who's been given the terminal diagnosis or who are already close to death. When I sit with a family, especially couples who have been married for a long time, I'll ask, how long have you been married? What was the first thing you thought when you saw her? Did you have a favorite dance or a favorite song? What was your first date like? If you were to buy her a present right now, what would it be? And I go to this place of, one of my favorite quotes is, my memories say hello, they ask about you all the time. I go to this place of memory. I want them to know that even though these last breaths might be taken, you still have your memories. And I don't want you to lose sight of that. So I try to take them on a walk down their own memory lane. So that's more elevated in their thoughts. You can't prepare someone, right? Any more than you can prepare them for their grief. People think, okay, I'm going to grieve, and they think it'll be over after a year, but no, it's going to be with you forever. I think the only way we can truly prepare someone is to be truly honest with them. I don't like to sugarcoat or lie. I want them to know what to be expected.
And those conversations are tough conversations, and beautiful conversations too.
Definitely.
Gabby, thank you so much for being on the show and sharing your knowledge with us. For those looking to learn more and get in touch with you, how can they do so?
The best would just be to go to my website, which is www. I don't think people use that anymore, but I'm so old school. So www.thehospiceheart.net. I have my classes on there. I have my blogs and poems. I have, I think, about 100 podcasts and interviews that I've done, and yours will be on there as well. And links to my books and other offerings. But yeah, you can find everything there.
Folks, as we reflect on today's conversation, I want to reassure you about something very important. Many fear that their loved ones suffer in silence as they approach the end of life, and it's natural to worry about that. But remember, with the right care, support, and understanding, we can significantly ease their journey, ensuring comfort and peace in their final days. Thank you for joining us. If you have any questions, please comment below or reach out to me directly. And if you found this conversation to be helpful, please like, share, comment, and subscribe. This is Traci Arieli from Comfort and Closure, wishing you peace and comfort in your journey. Until next time, take care.